to all of you and good afternoon. We're just going to wait a few more seconds here for some registrants to sign on. But I wanted to welcome you all today to Ellen Satter's webinar on our kickoff series. We've had such a wonderful response, and we're really looking forward to beginning here. So I'm just going to give it a few more seconds while we watch these numbers increase here. So I think we're good, and I think we're going to begin. So again, welcome and good afternoon. My name is Karen Tucker, and as the Executive Director of the Ellen Satter Institute, I wanted to welcome all of you today to our kickoff webinar series. As I said just a few minutes ago, the response has been so wonderful, and we're so pleased that you could join us today. Just to ensure that we're all where we're supposed to be, you are attending the Ellen Satter Institute two-part series on child overweight titled Preventing Child Overweight and Obesity, Raising Children to be Confident Eaters. And this is the first in a series of two parts, and that second session will take place next Thursday the 19th at 1 p.m. Central. Also, I wanted to take this opportunity to thank you, Ellen, for giving us this presentation today, for giving us and taking your time and expertise. There's a lot of content here, so I think you all will be pleased with what you take away today. And between the webinar and the handouts that are available on our website, ellensatterinstitute.org, I think you'll be really happy with what we have here today. So we're hoping to keep our webinar to 1 hour, and Ellen will speak for about 45 minutes and take 15 minutes for a Q&A session afterwards. And we're asking that you write your questions on the, there is on your drop-down menu for the webinar, we have a questions pane, and if you just press on that plus sign, you can type your question in, and we'll take those, and what doesn't get answered in the session, we will do our very best to address them afterwards. And it's fine to write your questions down as they come up to you during the webinar. You don't have to wait until the end. I do have another introduction to make. We're delighted to have joining us and co-sponsoring with us Tammy Frank, Dr. Carla Lester, and Holly Dingman with the Nebraska Medical Association. They'll be explaining the process of the CME credit after viewing the second webinar series, as well as talking about how they participate in child obesity and the programs they do as well. So with that, I will turn this over to Dr. Carla Lester.
Thanks, Karen. I'm Dr. Carla Lester with Teach a Kid to Fish, which is a nonprofit in Lincoln, Nebraska, working to prevent and reduce childhood obesity. And I also work with the Nebraska Medical Association's Childhood Obesity Prevention Project. I'd like to welcome you all to the first in the 2012 series of Foster Healthy Weight and Youth webinars, which will focus on prevention in the community. And would especially like to thank the Ellen Satter Institute for partnering with us and allowing us to be a part of this wonderful two-part series. We are pleased to be able to offer 1 hour of free CME and continuing education to those participants who qualify. The Creighton University School of Medicine designates this live activity for a maximum of 1 AMA PRA Category 1 credit. A detailed information sheet containing this information accompanied this webinar registration and may be found on the Creighton website. This activity has been planned and implemented by the Creighton University Health Sciences Continuing Education, the Nebraska Medical Association, Teach a Kid to Fish, the Nebraska Department of Health and Human Services, and the Ellen Satter Institute for the Advancement of Patient Care. I would like to tell you that neither the planning committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements claiming as such. After the webinar, you will be sent a link to the post-test and evaluation via email, and you may also visit cme.creighton.edu's website for more information. And I'd like to just take a couple of minutes to tell you about Foster Healthy Weight in Youth, which is Nebraska's clinical childhood obesity model. The clinical resources have been and continue to be disseminated to physicians across Nebraska, but can be used by anyone across the country as a clinical model. It's a comprehensive model with a toolkit, a pocket reference algorithm, a free CME training video which outlines the steps in assessment, prevention, and treatment in the primary care setting. And then there are also consistent messaging patient brochures and posters to resource clinics and offices. All of the resources have been free and are available through the NMA Childhood Obesity Prevention Project's website. As you know, today's webinar speaker is Ellen Satter. Ellen is a therapist, author, and lecturer. She's a registered dietitian and a holder of the Diplomat in Clinical Social Work. Her best-selling books, including Child of Mine, Feeding with Love and Good Sense, and Your Child's Weight, Helping Without Harming, as well as journal and magazine articles, teaching materials, seminars, and media interviews, have made her well-known to parents and professionals as an authority on nutrition and feeding of infants and children. And we are so excited to be able to collaborate on these webinars. And with that, I'm going to go ahead and hand it over to you, Ellen. Thank you.
Thank you so much, Dr. Lester. It's a pleasure to be here. And there we are. We've so enjoyed collaborating. I've so enjoyed collaborating with Ellen Satter Institute, a 501c3, which is separate from my business, which is Ellen Satter Associates. I run what is essentially a publishing and consulting business, and also so appreciate being able to collaborate with the folks in Nebraska. You know, I've been so optimistic as I prepared for these this webinar, these two sessions, and the other day I asked myself the question, you know, child obesity is generally quite a downer. What are you so giddy about? And it occurred to me that working from the feeding dynamics and eating competence model, we are defining the whole problem of child obesity in a way that it can be solved, in a way that parents can feel rewarded and satisfied about what they're doing with parenting their child, and they can achieve the goals that they set out in terms of their child's eating and weight. And so I'm very excited to share that with you. And those of you who've been with me for a while, you know what I'm talking about, don't you? And in fact, in presenting these webinars, I'm assuming that you are familiar with the theoretical underpinnings and practical application of the feeding dynamics and eating competence models, and that you're here because you want to check your thinking, that you're setting up interventions based on those models, and you want to make sure that they're consistent. But we're covering a lot of territory in these two webinars, so I really haven't had time to go back and teach the basics. And that's why Karen told you about this article, which is pretty comprehensive, and also told you about the Understanding Eating Competence, which is an article that is posted on my website. And I hope that you're able to get access to that. And it also, the link to that article is posted on the Ellen Satter Institute website. So let's just see if I can get this hyperlink to work, and if it doesn't, I will be in, oh, how about that? So once we're on the webinar, apparently I can't get my hyperlinks to work. Oh, there it is. It's going to the website. Now, in these, you know, most of the reading and the talking that I'm going to be doing in these 2 hours is to satisfy you that the models are legitimate and evidence-based. The two lectures are to help you understand what the models accomplish and why they work. Once you get to the application, it is really quite simple. And here we've gone onto the Ellen Satter Associates website, clicked on how to feed children. Well, let's just do it so you can see how to feed children. And then we page down to childhood feeding problems here. And there we are at the overweight child. Now this article is short and it is free. As long as you don't change it or charge for it, you may print this article off and give it to your patients. So the bottom line, the Cliff Notes version of what we're talking about and where we're going in these two webinars is to saying, rather than getting your child to eat less and slim down, support his normal growth and development. Getting started with family meals is critical. Maintaining a division of responsibility in feeding, well, chances are you know all about that. Feeding in a developmentally appropriate fashion, and maintaining a division of responsibility in activity. So if you understand all that, you can go home right now. You don't have to listen to any of the rest of this, but I'd like it if you'd stay. Okay, you're likely more familiar with the feeding dynamics model than you are with the eating competence model. I've worked far longer with adults than I have with children, but I started writing about children first, and so that's why you know me from that perspective. If you're following the division of responsibility, parents will take strong leadership with feeding while giving their child autonomy with eating. Parents do the what, when, and where of feeding, and children do the how much and whether of eating. With a positive feeding relationship, children's natural capabilities with eating are preserved. With excellent feeding based on DOR, the division of responsibility, eating competence develops step by step throughout the growing up years. Children are born feeling good about their eating, being able to go by their feelings of hunger and fullness to learn how much to eat. And as they grow up, they develop competence with food acceptance and with learning how to participate in family meals. If all goes well for children, they grow up to be eating competent. I developed this model in the first 30 years of my clinical practice in dietetics. I found that my patients simply couldn't adhere to the prescriptive diets that I was giving them. And in the process of trying, they lost their joy and comfort with eating and developed distorted eating attitudes and behaviors. So gradually over time, I developed a functional and more achievable conceptualization of what eating looks like when it is going well. And we'll be working our way through those parts today. ESI, the eating competence model, is a radical model. And you know, I put my name on all these things. You're probably starting to think I'm a real egomaniac. But that may be the case, but the primary reason I put my name on the models is to protect them from inaccurate interpretation. But anyway, as I was saying, radical doesn't mean extreme or fanatic. It means reduced to its simplest and most elemental form of or relating to the root. People have a natural desire to eat as much as they want of food they enjoy and to share good food with others. In my practice, I learned to practice dietary judo to go along with the natural energy rather than fighting against it. And I found when I did that, that people's eating became orderly and predictable and effective. As I just said, raising children according to DOR allows them to grow up to be eating competent. In infancy, parents get to choose whether the child shall be breastfed or formula-fed. After that, it's all up to the child. How much, how fast, how often, at what level of skill. The parent's job is to calm and organize the child and feed in a smooth and continuous fashion. You're likely more familiar with this version of DOR in feeding for toddlers and throughout the growing up years until the child leaves home. And again, parents do the what, when, and where. The child does the how much, and whether or not to eat from what the parent puts before them. Excuse me, I'm going to mute for a minute. Embedded in the division of responsibility are some assumptions. Notice that the parent will be responsible for managing the food and the structure of meals and snacks, and for making eating times pleasant by not struggling with the child around eating, but bottom line, by being there themselves. As far as the child is concerned, the most important thing at the table is the parent. The parent provides mastery expectations, shows the child what to learn, and accepts and supports the child's growth endowment. Notice it doesn't say choose and prepare healthy food. It says food. And that's the way I want it. Many of my fans edit that to insert the word healthy, but in my view, insisting on healthy food is likely to undermine structure. It's going to make it harder for a parent to get a meal on the table, and that meal on the table, or a structured family meal, is absolutely critical for following the division of responsibility. The key word in this slide is trust. If we do our jobs with feeding, children do theirs with eating. You can only observe a division of responsibility in feeding if you absolutely trust the child to decide what and how much to eat of what has been provided by the grown-ups. We're going to work our way through the 4 parts of eating competence to help you get more familiar with the model. I wrote this inventory during those 30 years I told you about. Barbara Losey and colleagues, then from Kansas State and now from Pennsylvania State, rigorously validated this test with over 800 people based on demographic questions, validated food and food management questions, and validated questionnaires such as Garner's Eating Disorders Inventory and Garner's 3-Factor Eating Questionnaire. Well, you can't read it, but we're going to go through it bit by bit, and then you can try this out for yourself. So read the item and then indicate by checking the box how often you think, feel, and do in the way that is indicated by the item. For instance, how often are you relaxed about eating? Always, often, sometimes, rarely, or never. How often are you comfortable about eating enough? So go ahead and answer the questions. And then moving on. The child who feels confident, who's confident with eating, has positive attitudes about it. And as I said, kids are born feeling good about eating. We don't try to run videos through the webinar because it makes a mess. Some people can see them and some can't. However, later this afternoon, Karen will send you a link so you can view these vignettes on your own. 4-month-old Emerson is from the Feeding with Love and Good Sense 2 DVD. I just got that out last year. And this is segment 1, the infant. This child is perceived by her parents and her nanny, whom we see on the picture, as being highly distractible. In feeding, they try to keep her attention and get her to eat. In other words, they try to do her eating jobs. In this typical feeding, Emerson is learning that eating is unpleasant, and that will interfere with her ability to eat as much as she needs, learn to like new food, and join in with family meals, provided the struggle that is starting out around eating at this point continues throughout her growing up years. If they resolve the feeding problem within a few days, Emerson will start to feel good about eating and get her regulatory abilities right back. To maintain the child's positive feelings about eating, it's essential to follow a stage-related division of responsibility in feeding. And in this article, again, there's a Cliff Notes version of what stage-related feeding looks like. And also on my website, if you go to the How to Feed icon, you'll see that there is a child development ages and stages section that describes stage-related feeding in very short articles. I mean, I tried to keep them down to 250 words. And so here's a way then to get some really good traction on what stage-related feeding looks like according to the division of responsibility. Well, what does this have to do with child obesity? Children are born with the ability to regulate food intake based on internal cues of hunger, appetite, and satiety. In fact, they are excellent regulators. They maintain homeostasis and grow consistently despite considerable metabolic and environmental variation. Children can also make up for errors in feeding. If a child eats too much one time, she'll compensate by not being hungry as soon or for as much at a subsequent feeding, or even by throwing up a little. Overwhelming a child's ability to regulate takes persistent and consistent interference. The parent having an agenda may constitute such interference. The parent wants the child to eat a certain amount of food, adhere to a particular schedule, or grow in a certain way. Based on that agenda, the parent ignores information coming from the child. Depending on temperament, the child defies the parent or complies. Either way, the static in the relationship with the parent becomes so pronounced that it undermines the child's positive feelings about eating, as well as his ability to eat as much as he needs to grow appropriately. And this can be anger, it can be sadness, it can be pitched battles. You've seen them, I think, in your clinical practice. So now let's take a look at your food acceptance skills. Only 3 questions in this category. Do you experiment with new food and learn to like it? This is the bottom line of food behavior that allows children and other people to have a nutritionally adequate diet. This is always, often, sometimes, really, or never. Can you make do? Do you eat a wide variety of food? Write down what your answer is, and we'll come back to it. Children want to grow up with eating the same as they do with everything else in their world. They pay attention to the foods that parents eat and ever so gradually push themselves along to learn to like those foods. They do, that is, provided parents do 2 things: give them opportunities to learn and avoid interfering. These parents give their toddler opportunities to learn, but unfortunately they work way too hard. They put a lot of pressure on him to eat certain amounts and types of food. Again, Karen will tell you how to find this video on the web. Not right now, but after today's webinar. So these 2 parents are doing just a fine job with doing the feeding. They have structure, they're showing the child what to learn, they're not letting him graze. They are not making eating time pleasant. In fact, they're making it darned unpleasant for themselves as well as for their child. And in the process, they are undermining the child's ability to interest in food, their ability to eat a variety, and his ability to grow up with eating. In fact, the child that's treated this way is going to like a smaller and smaller food repertoire, and by the time he's a preschooler, he might end up being one of those kids that 5 or 6 foods all by brand name. And so, you know, it's unfortunate because they're trying so hard, but it's really backfiring. And in fact, pressure does backfire. Adults playing both sides of the net is way too common. And in fact, studies show that 90% of parents pressure their children to eat. I spent a month in San Jose doing the taping for the DVD, and I was simply amazed at how interfering parents were with children's eating. And I don't think San Jose is the hotbed of parental interference. I think it's more typical than atypical. And my observations are backed up by this research. Almost all parents pressure children to eat and fail to believe them when they say they've had enough. Little wonder that half or more of children have feeding problems. As you'll see when you watch the Gage video, such interference spoils the meal for the child and makes him eat poorly. Gage is a toddler. Well, he's a person. He wants to be his own little person. But if Gage eats, it's going to be his parents' idea. To be his own boy, Gage has to refuse to eat, whether or not he is hungry. What does this have to do with child obesity? Whether the feeding struggle is about amounts or types of food, that struggle creates static, which in turn can undermine a child's ability to regulate food intake. The child could eat too much or too little. Either way, growth could be impaired. Some good regulators keep eating the amount they need no matter what, but you don't know which child you have, so you'd better optimize feeding. In a wonderful piece of research that goes along these lines, that was a group of Berkeley researchers followed 185 children of an original sample of 450 from age 6 months to 16.5 years. And they were looking to identify the precipitants of child obesity. In their final cohort, they cleared the usual suspects. Children who later became fat, compared with children who stayed thin, ate no more calories, no more low nutrient density or sweet foods, that is, no more junk food, were no more likely to have been bottle fed, started early on solid food, been given high-fat milk, or raised in single-parent families. However, the risk of later obesity increased with toddler lack of structure in feeding and with increased parental concern about obesity and with increased incidence of toddler feeding problems. So we have then the static. If we have a finicky toddler, we have static. We have struggles around feeding. If we have a child who's perceived as growing too fast or too slowly, eating too much or too little, we have struggles around feeding, and that then disguises the child's sensations of hunger, appetite, and satiety. Now let's take a look at your food regulation skills. Going into the video project, I had hoped to find a Matthew. You may remember him from the Feeding with Love and Good Sense 1 video. He was the 8-month-old crying pitifully because his child care provider didn't let him eat until he got enough. The provider had been instructed to do that by the mother, who reacted to the child's chubbiness and assumed that he didn't have a stopping place. We've posted that video for you as well. Today's parents still restrict. They just do it differently. When you view this video, you'll see that Gracie's parents have an agenda. They worry about their daughter's weight and try to keep it down by strictly controlling the amount she eats, avoiding fat, and getting her to eat more fruits and vegetables. When Gracie goes along with them, she loses track of her feelings of hunger and fullness. Other times, she's well aware of those feelings and has tantrums to try to gratify them. If you remember the pink splash I just showed you, well, I'm going to shut up and let you read it. If you remember the pink splash I just showed you, almost all parents try to get children to eat certain amounts and types of food. And here's the problem. Tomorrow's children who overeat and gain too much weight are today's children who are taught to ignore their feelings of hunger and fullness and eat as much as their parents want them to eat. This pink splash illustrates that it's only a matter of time until Gracie starts restricting herself. Studies show that children Gracie's age answer yes when asked, do you try to eat only a little bit on purpose so you won't get fat? Wherever the restriction comes from, it's likely to make Gracie fatter rather than thinner. Gracie's parents are wonderful about doing their jobs with feeding, with the exception of they're making eating times unpleasant for themselves and Gracie. I mean, who wants to work that hard in supervising what somebody else eats? Unfortunately, they're also doing Gracie's jobs, and that is taking away her food regulation skills and, pairing her ability with eating and with food regulation and in growth. In Gracie's case, the parents deliberately set out to obliterate her internal regulation cues in order to get her to be thinner than is natural for her. While parents may be able to achieve that at this young age, such children typically gain too much weight when they get to be 11 or 12 or 13 years old. At that point, they're out on their own, and they can get food in other places besides home. And even if they really, really want to do what their parents want them to, they just can't help themselves. And so they come home smelling a French fry breath, and parents find food wrappers under the bed. And it's very sad because the child is ashamed of himself. Everybody's frustrated. Nobody feels successful. I've repeatedly made the point about children's growing predictably, and that's the key word. This slide states the obvious. It's normal for children to grow normally. Very consistent, very smooth. Normal growth can be consistently at the mean, right along the 50th percentile. We're all comfortable with that when that upward predictable growth looks like this. It's steady, it's consistently tracking, it's average. But how about this pattern? It's upward, it's steady, it's predictable. This little person is charting his own curve right along the 3rd percentile. Its consistency tells us that it's normal growth for this individual child. However, this child is at risk of interference. Someone is likely to come along and try to get him to eat more and grow faster. That will introduce static into the feeding relationship and impair his ability to regulate food intake. After that, anything can happen with growth. Same with this pattern. Also normal, consistent, high and fast, tracking right along. This is the 97th percentile. This growth should be supported by optimizing feeding and activity and trusting the child to grow in a way that's right for him or her. But this child is also at risk of interference. Someone's likely to label this child obese and try to get him to eat less and gain weight more slowly. That will introduce static into the feeding relationship and impair his ability to regulate food intake. After that, anything can happen with growth. We know certainly that sometimes growth is uneven and adjustments are made. However, normal growth divergence is generally slow and gradual, and Curtis took 12 years to gradually diverge downward from the 97th or 95th percentile to the 50th percentile, and it's very smooth and gradual, so it's normal. This is a stock photo, and it looks so much like the child herself that it's uncanny, and especially that slitty-eyed look that says, I just dare you to try this on me. And what we're looking at here is uneven growth. And the more abrupt and rapid the growth divergence, the less likely it is to be a normal growth adjustment. And we have a sort of major adjustment here, another major one here. And such inconsistent growth should be investigated to find out what is going on. And if you can, it helps so much to go back and take a look at those records from birth on. And here we have Haley up until about 30 months of age. But you see that she was around 75th percentile. Her growth adjusted up to about the 97th and then leveled off at around the 95th. And despite the fact that Haley grew consistently for about 8 months, the doctor was concerned that by her plotting at the 95th percentile and said that she weighed too much. Now, this was in the chart. And so sometimes parents will hear inaccurately what their health professionals tell them, but this was correct. Doctor said weighs too much. Parents were very concerned about it, started restricting her food intake, forced her weight down to the 90th percentile. Still tendency toward obesity. So, I hope to heaven that this is an error, because if they forced her weight down to that point, they were frankly starving the child. Well, lo and behold, by the time she was 16 months old, Mom says voracious appetite. Well, of course. I mean, she'd become a toddler. She'd become aggressive. The kid was hungry. She was up and around and after food. And her pressure on food was just relentless, and she managed to get her weight up above the 97th percentile. Well, the family moved away. The new doctor was not worried about her weight, and probably, or perhaps even more importantly, that Dad took over the feeding. Mom was busy doing something else, and Haley's weight leveled off. We'll talk more about Haley next week. So the moral of this story for today is wondering about what is distorted growth. And it's that abrupt shift, the rapid crossing, and making the point that the shifts or crossing are at any growth percentile. If you get a shift that takes a child toward the mean, it's no less concerning than when the child is at the extremes, at the upper or lower percentile. And so what do you do when you have distorted growth? Well, you ask feeding questions. In the previous segments, we heard a lot about too much interference. In this segment, we're hearing about too little support. Let's take a look at your food context management skills. Until they're well into the teen years, children mustn't be made responsible for choosing food or orchestrating family meals. However, throughout their growing up years, they develop food context skills by learning how to behave at family meals. This vignette shows a positive example of parents who are providing their year-old twins with finger food and letting them feed themselves. They love it. Children this age care deeply about doing it themselves and are so delighted to be able to feed themselves that they eat almost anything. In 6 months or so, they'll show the toddler's typical pickiness. So this is really a honeymoon phase in child feeding. For children, the benefits of family meals reach beyond nutrition, and research with eating competence indicates that the same holds true for adults. Making self-care a priority speaks to the social and emotional health consistent with high eating competence. This slide illustrates some of the components of good parenting. We have eating dinner as a family. We have sleeping 10 or so hours, limiting screen and TV time. Presence versus absence of all three routines lowered child obesity by 40%. Having routine family dinner lowered risk by about 25%. The take-home message is that structure and routine are core interventions with both prevention and treatment of child obesity. And here's why. Structured feeding is critical in food regulation. Structure with feeding should be, must be introduced toward the end of the first year or the beginning of the second. Failure to introduce structure produces static. Consider the toddler who's too busy to know he's hungry until he falls apart, and then he's too upset to eat. Consider the toddler who keeps himself the center of attention by begging for juice, fanning the refrigerator door, refusing to eat at mealtime, and then begging immediately afterward for snacks. Being firm about structure lets toddlers come to meals hungry but not famished and willing to pick and choose from what's available, eating as much or as little as they need. Structure is the bottom line. Now, I'm about to say something to you that's probably going to be the most startling thing I'm going to say today, and that's from the How to Eat section on my website, Mastering Family Meals, Step by Step. Change the how first, think about the what later. In helping parents get some traction on meals, encourage them to start with the food that they're already eating. You know, it's hard for me to imagine how parents feed kids if they don't have meals, but they manage. I mean, they get a TV or they get a pizza and put it out on the counter, and everybody shows up when they get around to it and eats it, or, mac and cheese. Or they fan the refrigerator door and people kind of eat all over the place. So why not take those foods that they are currently eating and cluster them into mealtime and round up the family to eat together? And so this is the first step, getting the meal habit. And then instituting the division of responsibility at that point, which isn't going to be hard because it's all easy food, easy for the child to like, very familiar, unlikely to be many struggles around feeding. But they're, getting them ready because they're going to get bored with eating the same old when they start paying attention to it. And then they're going to start adding things on. For instance, they might add some broccoli and ranch dressing with the pizza, or put canned peaches on the table. And so at that point, it's important to teach the parents to let the child pick and choose from what they put on the table. I wrote these handouts on my website to be little tutorials for parents that they enter via the question that they're wondering about, and it takes them back to the basic information from there. So let's see about scoring ECSI. I'm going to give you a minute to do this. Give yourself 3 for every always, 2 for often, 1 for sometimes, and 0 for the other 2. I'm still here, still letting you score. Okay, still working, aren't you? All right, so let's add it all up and let's see what you've got. Generally speaking, a score above 32 is eating competence. Despite the fact that there are no questions about food selection on this test, people who score high on ECSI do better nutritionally with respect to weight regulation and have fewer symptoms of distorted eating attitudes and behaviors. They also have better health indicators. Blood pressures are better, blood lipids are better, and blood sugars are better. People with high eating confidence show better health. They're more comfortable with themselves and other people. This result attests to the growth and development over the years. As parents raise children to be confident eaters in the way I described, they're also raising them to be confident people. For my patients with whom I practice dietary judo, providing themselves with structure and eating the foods they like gave their eating order and stability. Adults practiced the division of responsibility on themselves. They got the meal on the table, and then once they sat down, they paid attention to their internal regulators of hunger and appetite and satiety to decide exactly what to eat of the food they put before them. And so nutrition turns out well when you have that structure in place, and then you depend on internal capabilities with regulation and acceptance. You can go to Your Child's Weight for more information, and this is the entire DVD that I've been talking about, and you're going to be seeing 4 of something like, 25 vignettes on that DVD. So here we have it, and it's time to hear from you. So here's the part where I see if I can take your questions. I don't have any messages, do I, Karen? Chat. I'm going to pull you out.
Do you want me to read a couple questions for you?
Yeah, I can't see them. How come I can't see them?
If you click on your questions, there should be a question on your pane with a plus sign to the left.
Yeah, on my pane, right there? No?
Why don't I start? Why don't I just read a couple?
Why don't you start giving me questions?
Okay. With toddler nutrition, how does a parent or caregiver restrict or monitor a child when he or she wants to eat the entire bag of chips or fruit snacks or food of low nutritional quality without feeling they are restricting?
Well, you ask a big question right off the bat. You know, it has to do with structure and with timing. Do I want to do that? No, cancel. I was going to show you my website, but who knows where it went to. But it has to do with structure and with timing. If you're going to, you know, offer the child, if you look on my website under using forbidden food, if you want the child to have chips or fruit snacks or whatever, introduce them at mealtime or snack time. Chips make a good accompaniment to the sandwiches. You can put on a whole, you know, bowl full of chips and let everybody eat as much as they want. I do have the recommendations for sweets at mealtime that you give everybody one serving only, because children will fill up on sweets at mealtime and not, you know, be interested in eating their other food. But that at snack time, periodically, you make sure that a child gets a chance to eat fruit snacks and milk or cookies and milk or, you know, some of these foods that people think of as being forbidden foods. But you put on as much as the child wants to eat. You offer snack time early enough so he's going to be able to eat, you know, quite a lot and still get hungry for the next meal. And you let the child regulate amounts. Now, you know, you're not going to do that every day, or even if you do, you know, children are going to get tired of cookies and fruit snacks, and while at first they might eat them like there is no tomorrow, they will, they'll get tired of them, and after a while they'll just eat a moderate amount and then go off and find something else to do.
Ori, that was a great question, and I think we have time, Ellen, for just one more. And I think this really addresses, this actually is a really great question too. So time for just one more, and then we'll have a quick summary from Dr. Lester and myself, and I think we'll be done for today. So the next question is, are children who have to restrict their diets due to things like celiac or Crohn's disease, are they at greater risk for obesity for the same reason as someone whose parents restrict their diet for the fear of weight gain?
No, I don't think so. I don't think that's a problem. That children know what they can and can't eat, and if they don't know, you can help them as a parent. You can help them do their own trial and error. They're going to discover that if they eat certain foods, it makes them ill. And you don't set them up to do that. You just warn them, you work with them, you explain to them one time what they can eat and what they can't eat, and then you just follow them along with trial and error. But the major distinction that you don't struggle about it. You just say this is the way it is, and you don't feel apologetic about it. You know, this is something about the child that he has to figure out for himself. Or that he has to come to terms with for himself. And so there's no reason why you'd be squabbling about it or having struggles about it. But, the bottom line is that the child can eat as much or as little as he wants. And that there are still lots of foods on the table, and the child can choose whether or not to eat those foods. And so you still are maintaining a division of responsibility. You're not trying to keep your child from eating as much as he's hungry for. There are whole other big areas of ways that parents can do their jobs and give the child autonomy with his own eating.
Okay, well, I think that for everyone who has taken the time to write questions in, and we really do appreciate it, what we're going to try to do is a group answer, so to speak. So I'll take these and sort them out, and Ellen will look at them and provide answers to as many questions as she can, and then we will just send them out to the registrants that have registered for the webinar today. So if you did write a question, you will be seeing your answer, and you can expect this probably in, I would say, the next 2 days or so. Does that sound good, Ellen?
Well, you give me time to get back from Indiana.
Okay, that's right.
I'm pretty busy with the grandchildren right now, so let's say by next Wednesday.
Okay. All right. Questions, answers back to your questions by next Wednesday. And Dr. Lester, can we turn this over to you? Did you want to just follow up on your childhood obesity prevention program and then cover the CMEs a little bit?
Yeah, thank you very much. Thank you, Ellen, for this wonderful webinar.
Thank you, Ellen.
Yeah, it was wonderful. I wanted to remind everyone that you may receive 1 hour of free continuing medical education credit. Those registered will receive a link to a post-test and evaluation via email, and you may also log on to the cme.creighton.edu website to receive credit as well. And this is just a slide that shows a little bit about our childhood obesity prevention project and the work we're doing in Nebraska and our clinical resources. And we'd love to hear from those of you across the country and have you use our resources as well. So thank you again, and we hope to see everyone next week for the next webinar. Thank you.
Thank you. Thank you, Dr. Lester. And I will now just be doing a short summary and follow-up for next week. Again, I think this has just been great and a lot of good information today. As a follow-up, too, you can visit our website, ellensaderinstitute.org. And if you did like what you saw today and would like to see more of things like this, as well as supporting research on feeding dynamics, you can do so on our Donate tab on the website, again ellensaterinstitute.org. Now, for all of you that have signed up for this webinar today, you don't need to sign up for the session next week on the 19th at 1 o'clock p.m. Central. You're good for that. And if you did not sign up yet, we are at full capacity. You can try to register. You can register anyway, and perhaps that person that did register prior to you won't actually sign on when Part 2 begins. So that's all for today. I want to thank everyone. Thank you, Ellen Satter. Thank you, Nebraska Medical Association. And we'll see you all again next